Hello, everybody, and welcome to the Paramedic Services Committee of August 8th, 2022. Attendance has been taken. We are moving to the approval of the agenda. I do have one request I would like to move just because there's been a slight emergency, so Chief King is not here at this time. So I'd like to move 7.4 to 7.2. Can I get, I guess, a mover and a seconder for that? Moved by Mayor Bailey, seconded by Councillor Pierce. So we're going to move 7.4 to after 7.1, if that's okay. All those in favor? Okay, and no one's opposed. Wonderful. Any declarations of pecuniary interest? Seeing none, we'll move forward. We have no delegations, presentations, or petitions. I'd like to have a motion to adopt the minutes from the previous meeting of June 6th. Moved by Councillor Sless, seconded by Mayor Bailey. Thank you. Any discussion? All those in favor? And moving on. Any business arising from those minutes? Seeing none, we'll move forward. So we're going to go to 7.1, Paramedic Services Budget to Actual Variance. There is a recommendation. Would somebody like to move the recommendation to get it on the floor, or should we have the presentation first? Moved by Councillor Pierce, seconded by Councillor Sless. And Heather, would you like to speak to this?
I'm just here for questions. So.
Just here for questions, if there are any. Seeing no, oh, is there a question? Mayor Davis.
Yeah, I've got a question about, so what we have before us is the budget year to date, so it's for 6 months of the year. And the intent here is that if there is going to be a budget overrun, that I think the intent is that we notify our respective municipalities. So this, if I read this correctly, I think it says that, I'm looking at it from the city perspective, that we're potentially going to be over budget. Looks like so far year to date, it's 132,000 by doing the math right. And if that continues, it'll be $265,000 to the end of the year, a not insignificant sum. So wanting to know, what is the projection to the end of the year?
Okay, thank you. Heather?
Through the chair. It's kind of hard to predict at this point, depending on like the continuing of the pressures both in the fuel and the vehicle maintenance and the staffing, upstaffing. Though, if those factors are mitigated at all, then we might turn around and come back to budget. So by the September projection, we should be able to have a better idea.
All right, and second, so are you notifying the, well, obviously county staff know about it, but have you notified the city finance department?
Through the chair, no, I haven't notified at this point. I was just working on this late last week. So.
Right, and so will you be sharing this with city staff once the motion's been approved?
I will be, yes, thanks.
Okay. Second question for you is, so I'm looking at the specific expense categories. There's 3 of them, and one is ambulance administration. And again, if I'm reading this right, it looks like we're over budget in administration, but we're under budget on paramedics. So that doesn't make sense to me. Why is that?
Through you, Mr. Chair, I know the paramedics line has been impacted by the COVID isolation, that we are segregating those costs out because they're separately funded by the province. So that's helped keep that line under budget. I'd have to get back to you further on the ambulance administration. I know that's largely wages, so I can look into that and get back to you.
Yeah, because what I'm getting at is I understand that we're facing a huge increase in demand for service, and there are issues happening at the hospital that are impacting paramedics. I would have thought we'd be spending more on paramedics, those who have boots on the ground and the same or less in administration. Doesn't seem logic to me. It doesn't seem logical that we're spending more in administration and less on actual paramedics. So I'd appreciate knowing why that is.
Okay.
Any other?
Thank you, Mr. Chair. Those are my questions.
Okay. Any other questions, Councillor Pierce?
Thanks, Mr. Chair, through you. It was kind of, Heather just kind of touched on it in regards to the fuel continues to be a significant cost pressure, but it states in there, vehicle maintenance costs are higher than normal as vehicle replacement cycle has been impacted by supply chain issues. What are we waiting on? Like what supply chain issues are we waiting on?
Through the chair, I believe we have ordered replacement vehicles, but because of the delay, the new vehicles haven't arrived, so therefore the maintenance on the existing vehicles has been increasing.
Okay, I thank you for that. I assume that was going to be the answer. Now, with that said, once we get into things a little further on today, as far as budget is concerned, I know that there is some lines in there for new ambulance purchases, we will call them. Are we expecting the supply chain to come around, or is this just going to be an ongoing delay? Do we know that? Do we have a feel of that? I know it's a tough question, but I'm just looking for your thoughts.
Chief King?
Good morning, everybody. I do apologize for being a few minutes late. And through you, Mr. Chair, the supply chain issue they anticipate will not correct itself till late 2023, 2024. We had a meeting back in May with the OAPC chairs, with the manufacturers of our vehicles, and everybody's waiting on chips. They say it is improving. They currently have on their yards about 200 to 300 bodies of ambulances that they cannot ship because of the chip issue. Some services are getting 1 or 2 at a time. Working with the CAO and Heather from Finance, right, they suggested that we put a deposit on these vehicles to get our name in the queue, but we do not anticipate getting these new vehicles that we ordered in 2022 to mid to late 2023, which is putting a strain on our replacement vehicles and the increased cost to maintain these vehicles at the same time.
Okay, I appreciate that. Thank you.
Thank you. Any other questions? If not, I have one. It's a bit of a follow-up to Mayor Davis's. Heather, when you talked about the COVID-19 sort of isolation and parameters costs there, that's covered by the province, would that end up sort of equalizing the percent of budget of the paramedics versus, say, the administration? And because the province doesn't cover the admin costs, and I imagine admin are not going down with COVID as often as paramedics are. So could you just add a little color to that?
Through you, Mr. Chair, yes, like the COVID isolation isn't impacting the admin line as much, and if that wasn't there, if the sick hadn't been covered, if the sick had been normal sick and not COVID sick, that line would have been more in line.
Okay, that's just good to know. Much appreciated. Okay, if we have no other questions, then we have a motion on the floor. All those in favor? And that carries unanimously. Thank you. Okay, so just to let Russ know, we did move 7.4 up to just make sure that you were able to get here for the other two. So we will go into 7.4 at this time, which is the draft budget, and we'll hold off on a motion because we have a lot of options. So, Michael, would you like to take point on this?
Good morning, Mr. Chair and members of the committee. We're pleased to present what is going to be, I believe, a challenging Paramedic Services Committee budget. I've got a few opening comments, and I'll apologize because I need to get a set of bifocals, so I can't actually see my writing very well in my comments, so you'll have to bear with me as I move my glasses around. But so I thought it'd be worth noting this is the 10th budget cycle that I've been part of here with the county. And it's by far the most difficult one that I think I've participated in over that 10-year period. So it's an interesting. I don't think we want to be alarmist as we walk through the scenario, but I don't think we also don't want to sugarcoat it because we are facing a fairly unprecedented, what I would call, crisis situation in the healthcare system. And emergent care is at the forefront of that crisis, and our paramedic service is at the leading edge of the emergency care system. So it is a complex, complex and difficult time for a municipal council to be looking at a budget when they manage a regional paramedic service. The service that we provide, we're statutory obligated to deliver service in accord with a set of regulated performance requirements that we have very limited influence over. And we're sandwiched in between an upstream system, which is the dispatch system, and a downstream system, which is the hospital system, that we have absolutely no influence over. So it leaves us in a difficult place to make changes to the service when costs start to become pressured. There's a number of unique challenges that we're facing right now. We've actually already touched on a few of them, but I think all of us know we're living in inflationary times. I had a look at the 12-month trailing CPI for Canada through StatsCan. It's sitting at 8.1% at the end of June. I don't know whether it's approved a little bit over July. I didn't see a July number. So that's impacting a variety of our costs. The 50% cost share that we've always enjoyed for the service with the province has historically been in place, but that historical cost share doesn't seem to be holding anymore, and that's articulated in the budget report. To set that cost share, we rely on them to pick a budget year, and right now we have a delay in that budget year, and we also aren't seeing the province reflecting inflation as we move into the future year budgets. And so that results in our cost share being significantly less than the 50%. And what that results in is that the municipal taxpayer has to pay more of the increasing budget for the service. So compounding that further is a lack of information. And I've chatted with the chair and Mayor Bailey about that, as well as staff. As of this date, today, August 8th, we still don't have our 2022 allocations from the province. It's my understanding that the provincial budget is supposed to be tabled later this week, and whether we see some movement for paramedic services in that remains to be seen. You know, another unique challenge we're dealing with is that the paramedic service calls for service are outpacing the rate of population growth by a considerable margin. This is a healthcare-wide situation. It's not just unique to paramedic service, but it's driven by a mix of things, population growth being one of them, but a small component. A bigger component is an aging population that's more likely to require an ambulance. It's also being compounded by a lack of other services that can divert patients out of emergent care and into, I think, more logical services, such as a robust family medicine system, which currently Ontario is struggling with. The lack of walk-in clinics, which are actually declining as opposed to increasing. Things like mental health support services, a stronger long-term care system, more in-home or home care services. I could go on and on. So the lack of these services is pushing people into emergency rooms and pushing people towards paramedic services to get them there. And there's a documented propensity for new generations, subsequent generations, to call an ambulance where previous generations wouldn't. And so that's also, we call that the factor here in the paramedic service, and the factor is increasing every year. So in 2016, we undertook a strategic review of the service. It was co-led by myself and the city CAO at the time, and we presented it to both councils, and it did project calls for service increasing by 6% annually from 2017 to 2025. And that projection was supported by a detailed population and demographic analysis. Based on this, it identified the need for us to add a 12-hour paramedic crew in each of 2017, 2019, 2021, and 2023, or in essence, 2 full ambulances over the course of that time period. And generally, we've not been too far off of that with the downward bump in COVID calls and then the following upward surge in calls for service. Now, we've been averaging since 2017 about 6.5% in increased call growth. And we've added 1.5 staffed ambulances since the time. So we are still on track, and that exercise was not incorrect, although a little bit lower than maybe what's transpired, and it certainly didn't project COVID-19 happening. Eroding our performance during these times, though, has been an increasing lost efficiency from ongoing offload delays, the additional lost efficiency from COVID-19 protocols, and the insertion of those new resources on a later time frame that was projected in our 2016 system. But generally, I think we've done a good, as a group, we've done a good a good job of keeping the service resourced to deal with the challenges facing it. So, Mr. Chair, those are my opening comments on the background context to our 2023 budget. As I said, it's difficult, but I'm sure we can get through this. I hadn't planned on reiterating in detail the budget presentation, which was outlined in the report, I think, fairly smoothly. But I thought I would just make a few brief comments as to the budget itself. And so on page 3 of the budget report, of our staff report, there's a summary table of the base budget, base operating budget. It notes that the services expenses are increasing by 4.5%, and that's offset by provincial revenue projections only increasing by 2.6%. And so as I mentioned earlier, that pushes more of that increase onto the municipal tax levy. And so overall, we have a net levy increase of $454,000 or 6.4% overall. That's just the base budget. But we are presenting 4 decision packages, these being a request to review the service and our deployment model, which we haven't done since 2016, the creation of some what I would call additional supervisory and administrative support, noting that the model that we currently use for administering the service hasn't changed very much since we took the service over in the year 2000. And then finally, and most notably, the addition of a 24-hour ambulance. I'll get to that in a second. On page 5 of our staff report, we've summarized the budget drivers into some broader categories. I think that's fairly self-explanatory. And on page 6 of the report is a table that outlines the service's key call projections and the associated resource consumption, noting that presently and into 2023, the service is operating beyond its theoretical capacity, and that's resulting in our request for additional resources. Appended to the budget report is a detailed budget, line-by-line budget. That's found on page 29 to 31 of the package, and I think it's, again, fairly self-explanatory. And also appended is a 10-year capital plan and the associated capital reserve position, showing that the reserve does trend into the negative, which will be a challenge for future budget years. And maybe later in the discussion, I do have some thoughts on some things we might want to think about over the course of the 2023 budget year that we could do to mitigate some of those issues. So, Mr. Chair, those are my comments, and I'll just close with the thought that budgeting for a frontline healthcare service in the midst of a healthcare crisis is difficult in a lot of ways. And so we don't know where the crisis is going. We don't know what the province intends to do about the crisis right now, and we don't know what our healthcare partners are intending to do about the crisis. So we have a lot of unknowns. We have financial unknowns and operational unknowns as we move into this budget right now. So we are still in mid-year, and I think that's a good thing. Time is on our side, and so we can certainly discuss the timing of the need to approve this budget. We have a schedule that's in the Paramedic Services Agreement, but it has some leeway in it as well on the agreement of the 2 municipalities. So we may want to think about timing right now. But with that, we're pleased to assist committee with its analysis and deliberations on the 2023 draft budget. Chief King is with me. Our County Treasurer, Heather Mifflin, is here. Our General Manager of Corporate Services, Heather Boyd, is here, and Adam Crozier, the project lead for the CAO's office, is also here. We all contributed to the budget process, and we're happy to answer any questions. Thank you, Mr. Chair.
Thank you. Much appreciated. A lot there. So we have performance requirements, inflation, COVID, dispatch, emergency offload, unknowns regarding provincial funding for this year, let alone next year, growth of our communities, aging of our communities, and also one thing that wasn't mentioned in your report that I'd like to mention before we get into our deliberations is that we've had previous reports of this committee that we are among the leanest paramedic services in the province, and that still holds true. So there's a lot there to unpack. And to start us off, Mayor Davis, questions and comments.
I got a lot of questions, and comments. But first of all, I want to make sure I understand the timeline. And so we do have an agreement between the city and the county, a timeline for approval of the budget. And because this is an election year, I realize that's been modified. And the reason for that is because the new councils won't be in a position to approve their budgets until January, where normally they would try and do it in December. So my question to you, Michael, is through the chair. What is the timeline? Like when does this, and I realize it's been amended, it's been changed for this year only, but what is the timeline for this committee making a final decision on this budget before and thereafter, then present to the respective councils? So what is that timeline?
Thank you, through you, Mr. Chair. So the timeline, the timeline for this committee is it's supposed to have a draft budget presented to the two councils by October 1st. And then the two councils have some obligations to get comments back to Paramedic Services Committee. So we've got till October 1st, according to the existing amended agreement for the election year. Now, if we don't do that, if Paramedic Services don't do that, then the assumption is then last year's budget would be forwarded to the two councils as the current budget, subject to Paramedic Services presenting a new budget. Notwithstanding all that, and there is language in the agreement that does contemplate that the committee or council may want to defer the budget, and that would be on mutual agreement. So again, we have some options. And I think the reason I present those options as a notion is that we do have a lot of unknown information that we're, a lot of assumptions in this budget without a lot of hard data behind them. So, thank you.
Yeah, and that's a concern that I have. So normally we what, September, but because of this being election year, it's now October. I got that right?
Through you, Mr. Chair. No, I think the October date is the current the standing date. The change in the budget, the election year stuff is about when the comments have to get back, and that's all delayed until January because it's assumed that neither council will start its budget process in January. So again, Paramedic Services is supposed to deliver a budget to the city and obviously to the county through its own reporting by October 1st. December 1st, the city council is supposed to have reviewed the draft budget and either approved it or provided questions, concerns back to the county. And then January 31st, the draft budget and notification of the city's position is supposed to be presented back up from the county council, supposed to be presented back to city council. So those are the later dates in the election year.
Right, and so, Mr. Chair, I think when I look at this budget, if I take a similarly high-level overview, the big decision package is an extra ambulance. And I accept, given the increase in demand, we got to do that. But the question is when you do it, right? Do you do it at the beginning of the year? Do you do it in the middle of the year? When do you do it? And it would be really helpful to know a couple of things before we make that decision. One, what is the province decided to do about its portion of ambulance paramedics funding? And we've got a provincial budget coming down, I believe, within the next 2 weeks. We have a delegation at the Association of Municipalities of Ontario annual conference in Ottawa this coming weekend. It's a joint city-county delegation led by Mayor Bailey. Then one of the issues is this whole issue of paramedics funding, and we'll be meeting with representatives from the Ministry of Health. We have the issue happening at the hospital right now, the crisis there, and it's not clear to me, since neither the city nor the county runs the hospital, exactly what's causing that. Is that due to summer vacation schedule of staff, or is it something else? And probably that really won't be, I suspect, known until we work through towards the end of August. So I'm going to be, at some point, moving a deferral of our final decision-making in the budget to September, when hopefully we have some of these unknowns will then be known, so we can make a better decision. I think the decision, in my view, is when do we do the extra ambulance? The other question I have for you, Michael, I was listening very carefully to what you were saying, and you were talking about this increase in demand that exceeds what you would expect based on aging of our community and population growth. In fact, I looked at the stats report, it's a 15% increase this year, which far exceeds the aging factor and the population factor. And then you got the offload delays at the hospital doubling, which further complicates everything. So I think in response to that, you said, obviously one solution is you increase the ambulance capacity, but I take it there are other solutions. And I think when you said we, meaning the city and the county, have limited ability to make changes to the system, what changes would you have in mind, or do you have in mind, if we had the ability to make them?
Thank you, Mr. Chair. Through you, and I might turn this over to Chief King, but I think more broadly, you know, the system, and I can think back 6 years ago, going to a meeting with the Minister of Health, lobbying for change in the paramedic system, not only for funding, but for systemic changes. So things like changes to the dispatch model, which would be a little more flexible in terms of how an ambulance or a paramedic crew is dispatched, changes to how we can utilize paramedics in the community better to keep them out of the hospital and into people's homes where they can provide supporting care, changes to, and I think I saw some dialogue between yourself, Your Worship, Mayor Davis, and Chief King about utilizing different. I think there was a discussion in some other jurisdictions using taxis, for example, to send low acuity patients to other healthcare services as opposed to using an ambulance. The certainly increase in the use and the capacity of the community paramedicine program to get paramedics out there into the community, helping people and not moving them into an already overextended healthcare system. Those are just a few, and I don't know whether Chief King has other thoughts, but there's his group, the Ontario Paramedic Chiefs Association, has a ton of thoughts on this, and they're aggressively lobbying the province and have been for many years, I believe, Chief, on these systemic changes, and they just don't seem to be coming. And I think so. We're caught in this. I don't want to call it a trap, but a system where we just continue to dispatch ambulances, continue to move patients into what seems to be an overextended healthcare system, and there's other options. And certainly, as I've gotten to know the service better, in talking with Chief King and his staff and his colleagues, there are a lot of jurisdictions doing a lot of other things in emergent care that we in Ontario are not doing. And I don't know why we're not doing these, but I think this is the lobbying that collectively, and I think Chief King and his group need to do. And I think we as municipalities and all of our supporting municipal partners need to be doing. But I'll turn it over to Chief King to see if he's got other thoughts, probably more well articulated than mine.
Chief King?
Thank you. I'm just getting used to this new system here. Through you, Mr. Chair. Michael did touch on a lot of points, but to answer Mayor Davis's questions about aging population and the population growth, right? It's not just those simple factors. It's the lack of urgent care, lack of family doctors, people that have those backlogs on surgeries and stuff that really need this treatment right now are at an impasse because they're like millions of surgeries backlogged. They call us because they're basically at the end. Their pain has increased. Their critical calls have increased. So more of the onus is basically we're considered by a lot of agencies as a safety net, right? The paramedics will still be there to help them out, right? We've worked with the hospital. We continue to work with the CAO and both in the county here and with the CAO at the hospital coming up with ideas. We have had many meetings. Some of the ideas as the CAO referred to in our OAPC working group. The province has announced, but we have not seen any funding or funding letters yet for increasing the dedicated offload nurse structure currently at the hospital. Currently, we pay the hospital through our transfer system for a dedicated offload nurse. They're looking at doubling or tripling that funding, but it doesn't have to be solely relied on the healthcare system of the hospital to do so, right? They've changed the wording that paramedics could transfer patients to their areas. We have not seen the bill or the funding model as of yet. The CIO did refer to dispatch models. Currently, Toronto, Ottawa, and Niagara have a different dispatch model where they actually have a doctor/nurse into the dispatch center. They help select the acuity of care, and they can either send out mobile response units to treat the person, or an actual ambulance is actually dispatched. Mayor Davis did see the article about them using taxis. Again, some of the taxis things, there's been some hiccups as I talked to the chief down there, but they're looking at different solutions to help with our crisis. Currently, right now, we have a great community paramedic system, which we anticipate diverting 5,000 calls annually, and it continues to grow with palliative care and mental health. But again, if the province ever removed that funding, that's 5,000 calls more into the system. The CAO and myself have had many ideas. We're currently formulating an idea I have dealing with responses for paramedics. But with our call volume increase and our over 14% increase, we are now relying on our community partners, being Oxford, Norfolk, Haldeman, Hamilton, to do almost 1,400 responses into our community, which we've never seen before. And in our forecast, we'll only do 400 to them as we transfer patients into the Hamilton region. So that's 1,000 calls that we will be responsible for the anticipated cost of cross-border billing. I'm hoping it's a lot less, but currently that's our forecast right now.
Okay, Mayor Davis, it's been a bit here, so I'm just gonna stop you for a sec. I'll come back to you. Just want to see about other questions. I do want to add though that, I see a trend here that we saw with policing. This is, the subject I teach in, which is services in the community around crime prevention, cut, restricted, and what ends up happening is then we put more money into policing to deal with things like mental health, et cetera, and we're seeing a sort of similar trend here where there are things around poverty systems and around health systems that have been restricted or cut at other levels of government. And, again, just like, well, we can always call the police, well, we can always call the paramedics, and that provides a pressure to deal with the number of calls. I'll also add that London, and I just wrote about this in a book I recently wrote, London, they have, some of their paramedics drop, people who are experiencing issues due to drug use to their version of St. Leonard's, right, and different community centers that do those drops, so they're not filling necessarily the hospital wings if it's that kind of crisis. And the same thing with general mental health, where they'll drop them at a mental health center as opposed to the hospital all the time, which can be a long wait. So there are other models that are local or local adjacent that we also could be looking at as well. Enough of my commentary. Anybody else have questions before we go back to Mayor Davis? So I'm gonna go to Councillor Pierce because he has a question. Because I gave you 11 minutes. And
Thank you.
We'll come back to you. We'll do 3 rounds if we need to. Councillor Pierce.
Thanks, Mr. Chair, for you. I totally agree with a lot of the points that Mayor Davis was making there. This is very difficult because of the unknowns.
Pardon me, John. We can't hear you very well at all. We can hear you, but it's very tinny, and I don't know if it's on our end or your end.
My apologies. Is this any better?
We think you may have 2 devices running.
Nope. No, I don't. Just let me throw some. My apologies. Go back to Mayor Davis and then come back and just throw my headset on.
Okay. Anybody else before? So due to technical issues, Mayor Davis, you got your second crack now.
Yeah. I'm not sure. I guess this question goes to both Michael Bradley, through you, Mr. Chair, and also the Chief. And I hear your frustration, and I think members of the committee, we're feeling the frustration as well. A lot of this is happening beyond our control, and we're having to deal with it. Like, for example, what's happening at the hospital right now with the ambulances staying there almost double the amount of time they're normally there. It's almost like it's a separate unit of the hospital, and if that helps them get through this crisis, which hopefully is temporary, then that's what we do. But I'm also hearing, and I read in the stats, that this increase of 15%, like, I'm trying to understand it because population growth is around 2%. The aging factor is probably around 2%. And so something's going on that I think needs better attention and better management. And yes, I want to see us put another ambulance in place, but surely that isn't the only solution, the only option that's available to us, other than citing a number of issues with the province. What about, if I look at other services in Ontario, and some of them are being pretty innovative, I guess Niagara's one. I'm not saying we follow what they've done, but I think if I understand correctly, what you're telling me is Niagara, because they control their dispatch, they're able to, like, for example, have a doctor there or a nurse taking the calls and figure out who needs an ambulance right away and who doesn't need an ambulance right away. Why can't we do that?
Through you, Mr. Chair, the province created pilot projects with Ottawa, Toronto, and Niagara about 5 to 7 years ago, and the pilot projects never got out of the pilot system, and the province continues to fund that. There are things in the background that currently I am not allowed to share, but there is a move forward with our group within our region to model the dispatch center in Hamilton similar to what Niagara has. One of the chiefs in our region is leading that, but that's as much as I'm allowed to say at this point in time.
Well, why aren't we trying to get control, do our own dispatching, maybe jointly with fire for our area? Because a lot of the calls fire responds to are like ambulance-like, they're dealing with health issues. Why don't we take back dispatching and do it here, and we can implement solutions that are unique to our area and innovative, and we'd have more control over an important part of the system.
Through you, Mr. Chair, one of the enhancements, and actually Brantford was one of the first ones chosen to do so, is the new dispatch system. Currently, right now, Peel Region was the first to launch. The new dispatch system really changes the overall acuity of calls coming to our area. The old system was called DPCI 1 and DPCI 2, which is a very antiquated black and white system. The new system will allow us to defer calls, reroute calls, allow them to call telehealth and stuff. But the new system is the different levels of responses. Our staff actually start the training on the new radio system at the end of August, beginning of September, and we hope to launch by early January. That may defer some of the, every call gets an ambulance. We hope to do that as the first step. But as I said, there is a push in the background to have the same modeling as Niagara currently has in our area. We, prior to me arriving in 2000, the dispatch center was centralized in Brantford for all of Brantford, actually out of 303 Henry Street from, I believe, 1985 to 1997 before the province took that over and made the central ambulance dispatch center in Hamilton. There is works in the background of what you're suggesting, Your Worship, but right now I just cannot allude to any more information that I have at this time.
Okay, if I can just ask, Mr. Chair, one more question on that topic. So right now, the province pays 100% of the dispatching. Is that what you're saying, Chief Kings?
Correct.
Yeah.
Through you, Mr. Chair, I do apologize. So the model that they're aiming for is, if we can do the Niagara one that we're doing the research in the background, is the province will fund 100% of that dispatch center. It'd just be like a rollover payment, but we want to extend the extenuating or add the features and the flexibility currently that Ottawa, Niagara, and Toronto currently have.
All right, and the fact that we're part of a much larger group, including Hamilton, does that restrict the options, because the whole system might be Hamilton-centric? I'm not saying it is, but are we better off trying to get our own dispatch back?
Through you, Mr. Chair, I think it benefits us, not handcuffs us even further. With the resources, the building, the transfer, I think it would benefit us more than just us having our own dispatch center here in our region.
Last question. You said there's things happening in the background that could be very innovative, and I take it from the tone of your voice, you're kind of excited about it. When will we know about that? Will we know that September, October? When will we have news on that?
Through you, Mr. Chair, with the change in the government right now, there is momentum starting as far back as January, February, and March of this year. We last met in May with the election and now the sitting. I'm hoping to have some more information by September or October of this year. It's all depending on the provincial government and how fast they move.
Okay. Thank you, Mr. Chair. I have some other questions, but I don't want to hog the
Thank you.
question.
I think the CEO Bradley has some comments as well, though, on what you were speaking to.
Thank you, Mr. Chair. I think that's good discussion, and I think just want maybe to clarify, or maybe so there's no confusion. So both the city and the county, we have a fire service, and our dispatch, we have control over dispatch, so we can run a dispatch, we can contract it out to a third party, we can not do dispatch, I guess, whether that's an option or not, but I think the paramedic service, that's out of our control. It's run by CAC, CCAC, and it's provincially run. It's provincially funded, it's provincially run, and it's operated under provincial guidelines. So I think what Chief King is saying is that, and we were lobbying this upwards to 6 years ago, that that model is not working very well for paramedic services right now, and I think that's something we need to continue to lobby with the province about. And I would agree. I think it would be nice to have that option to take dispatch in-house or to work with other partners, pick your partners, and design your dispatch system based around the individualities of your service. So, thank you.
Well, thank you. Okay, Councillor Pierce, let's do a sound check.
Okay, is that any better?
We hear you perfectly. Wonderful.
Okay, excellent. My apologies for that. Yeah, thanks, Mr. Chair. Through you, as I was starting to say earlier there, yeah, I agree a lot of the comments that Mayor Davis has made there with the fact of the unknowns. And speaking of the unknowns, when it comes to the the provincial share of the 50%, which as we have found that it is actually less than the 50%, somewhere around 47 point something, I think, if I recall in the notes. But my question is that we know that it's less than 50%. If you want to call it, the agreement with the province is there to pay 50%. We're not the only municipality that's under this agreement, so to speak, and I'm only assuming that they're all getting less than the 50% as well. I'm curious if there's been any acknowledgement, from the province that they do realize that it is less than the 50%, and if in fact that is the case, that's part of the battle. But what if any comments are they saying about potentially getting it back to the 50%, or does it appear that things are just going to stay as they are, or is it, heaven forbid, are they going to go the other way? That's my first question, if I could.
Michael, do you want to start with that?
Sure. Through you, Mr. Chair. Sir. And Chief King might have further insights on this. In terms of is the province aware of this? I believe they are. Mayor Bailey and I sit on the Western Ontario Wardens Caucus, so it's a group of upper tier municipalities in southwestern and western Ontario, and they are all paramedic service managers, and all of them are fretting and frustrated by this situation, and have been for 4 or 5 years now, because the situation seems to be getting worse, not better. So I think the province is very aware of this. B, the municipalities that deliver paramedic service have been, I think, quite vocal in this. I remember it was quite well discussed in, I think, 2019 at AMO. There was quite a bit of what I would call terse dialogue at one of the provincial ministerial sessions on this topic, certainly with the upper tier municipalities and service manager municipalities. So yeah, I think the erosion of the provincial cost share is well known. It's well documented in municipal circles, and I think there's been provincial volatility around paramedic funding since late 2018, where there were some thoughts about new service models thrown out, and then those seem to have gone away, and then there was thoughts about maybe changing the funding formula, and then that seems to got parked when the pandemic struck, and now we just seem to be in a bit of a waiting period. Now the province did put forward a lot of funding to stabilize paramedic services through the pandemic, and that was welcome, but that funding, we're not sure what the future of that is. We're still impacted by COVID-19 as a service, but we're unsure about the funding. And again, to Mayor Davis's point earlier, the provincial budget is supposed to be tabled later this week. Whether there's and I think there's a lot of, I'll opine, I hear in the media, there's a lot of discussion from a lot of commentators that I think people are looking for the province to be putting healthcare forward as a critical need in this upcoming budget. But I think the draft budget was tabled before the election, and it didn't have a lot of change in that. So, thank you, Mr.
No, fair enough.
Okay, yeah, and thank you for that, Michael. Yeah, and then they're discussing with them, going back in for a seating this week and stuff like that. That the healthcare services are, they're aware of it. So we'll see what comes out of that. Okay, appreciate that. What I'm getting from that is the fact that they're aware of it, but at this point in time, there's no commitment to do anything about it. Which I'll leave that alone. A couple other quick points, if I could, Mr. Chair. First of all, when we talk about call volumes and stuff like that, all I can say is, thank goodness for the paramedicine program that we have going, because as Chief King stated there, that would be another like 5,000 potential people to BGH, which is would just I don't even want to fathom what that would do with the wait times and stuff like that. So thank goodness we have that, and kudos for the way that we're doing that. As far as dispatching, I want to just touch very quickly on it. I guess if I'm calling for an ambulance, I can say whatever I need to say in the back of my mind to get an ambulance to my place. And I think with dispatch, it's very difficult. And I'd be interested to see how it all unfolds and when more information becomes available about potentially having a doctor at the dispatch, because I would like to understand if and well. I suppose it does, but I would like to understand actually how many calls it does divert from sending an ambulance. Because as I say, and I don't need an answer on it right now, but I'm thinking if I'm calling for an ambulance and in my mind I need an ambulance here, I'm going to say whatever I need to say in order to get that ambulance. All of a sudden the ambulance shows up and I don't want to make light of it, but I've got a cut finger or something like that. So I think that's going to be a bit of a struggle as far as the dispatch. So I'm interested to hear how that all unfolds when we're allowed to get more information on that. Just the last thing I want to touch on here, and we've all spoken about it, when we talk about the numbers, the stats are what they are. And we all agree that there's a huge increase in the number of calls for service. And as Mayor Davis alluded to there, yes, there's aging, there's population, stuff like that, but there is something else happening within that equation that I'm curious about too. And we talk about throwing another ambulance at it, that would assist in getting the call to the hospital, so to speak. It's just going to exasperate the whole wait times. But my question on that is, and I spoke of it earlier, we're on delays for ambulances, and then we're also with the extra maintenance on our existing vehicles that we're using. So my question is, if we look at the budget over the next couple of years, there's potentially 8 new ambulances that are budgeted for over the next couple of years. I'm curious, A, do we have enough existing fleet right now to take this additional ambulance and put it into service? That being said, what would obviously we want to save vehicle and stuff like that. That goes without saying. But is that just going to exasperate the whole maintenance fees and all that kind of stuff? So if we were to put a new ambulance on this straight away, do we have that vehicle, or are we in a bit of a conundrum here where we're waiting for a vehicle to be delivered?
And so I'm going to have Russ answer that. Russ, can you also add to that a bit of what Mayor Davis was talking about, which is when he was asking about the when, would that fleet piece factor into the when of hiring or adding an additional ambulance in that decision package number 2?
Through you, Mr. Chair, I'll start with Councillor Pierce's question first. Is over the years, with the anticipation of our growth, right, from the original consultant's report in 2015 that we'd have to go up 5%, we were seeing the need to keep some of our other vehicles, as we refer to as spares, a little bit longer. So we've already forecasted that. Currently, right now, we run with 4 spares. Our friends at Northway basically had to do an excellent job of that. If we break down, they get us on the road within 24 hours, right? So adding an additional vehicle, if we do choose to do so as of January 1st, would only basically put us into a tighter constraint about having spares until mid-2023, right? Even if we started off with something as of January and then we added to it, whatever the overall model looked like, right? We'd be able to do it to meet the needs right now of the community, right? We have great relationships, and it would be basically 6 months of very tight maintenance schedules for our current vehicles until we get our other ones. Originally, the forecast was late 2023. They have improved. Now they're saying mid-2023. So as more and more chip manufacturers come on board, right, they'll get the chips ready, they'll get them out as fast as we can. But we've forecasted not this type of crisis situation, but keeping a fleet for what if. Because right now, currently in the past, if a vehicle got into an accident and it was unrepairable, we'd call our manufacturer and they ship us a new one next week right now. If one goes down right now and we get into a crash, that limits our resources. So we've kept them a longer than we originally anticipated. Through you, Councillor, what was your other part of your question?
No, actually you answered it, that if we were to hire in January 1st, we would have the fleet. It's not going to affect the analysis of when we should hire a new ambulance. No, that's fine. Okay, thank you.
Thank you. And Mr. Chair, if I could, just one final on that. So let's just hypothetically say we add this new ambulance in January. So we have a 724 additional ambulance with the code zeros. Is there a thought as to how many code zeros that potentially could eliminate? Because as you said, right now we're in a situation where we have potentially 1,000 calls that we're going to have to pay for cross border. Is there any discussion as to, okay, so now that we have an extra ambulance on there, that's going to reduce potentially the code zeros by 1%, 5%. Has there been any talk on that?
Through you, Mr. Chair, you've asked a lot of great questions all at once there, and I'll be able to give you the best answer possible. First of all, deferring 1,000 possible other EMS services doing calls in our area, it's not a perfect world, but if we were able to cut it down by 50% of what we're paying outright for the first year that we started, we hope to be more. That's 500 calls times the current rate right now. It's $100,000 to $200,000 savings. Ideally, when we talk values of 24-hour ambulances, right? It's not to the point of just I'm putting on a 24-hour car as of that. We use the 24 hours to hit our peak times. If we saw our graph that we see updated every minute of every day, we start peaking at 8 a.m. and we start leveling off at about 3 o'clock in the morning. So if I would take that 24 hours, and this is not moving forward any past your question, is I would put on maybe a 10 to 10 car and a 2 to 2 car, basically helping us where our worst peak would be, separating those hours for the 24-hour usage to have the best impact, not just putting on a car from 7 a.m. to 7 a.m. the next day, right? We'd use a better deployment plan to maximize our resources, decrease the code 2s, and also decrease the code 2 status. The hospital has been trying to work with us. The new dedicated offload nurse ideas, we've talked to them, as you may have seen in the newspaper on the weekend, using the Willet as urgent care. We're working on solutions in the background. Myself and the CAO continue to meet with them to come up with brand new strategic ideas. That's how the money would be utilized.
Thanks, Russ. I appreciate that.
Thank you. So yeah, we'd be looking at a $100,000 to $200,000 savings potentially. Plus then the provincial funding the next year of either 487 or 243. Okay, Councillor Sluss, I see your hand up. You've been very patient. Thank you.
No, that's fine. Thank you, Mr. Chair. Just one going back to a question Mayor Davis asked earlier about the budget to actual. I don't believe the chief was here at that time, but that the administration is running a little better than 5 points over budget, while the paramedics budget is running slightly under budget. And we didn't really get if he could give us a sense of how that could happen.
So before you were here, Heather had talked about how the COVID protocols that the province pays for has downplayed the paramedics percentage a little bit, but do you have any other insights? Oh, green, yeah.
Through you, Mr. Chair, the increase in the admin side is we do not have the capacity to backfill some of our staff. We've used additional resources. We do currently have an additional admin person to deal with our scheduling situations that we currently have right now. Right now, we have had, as the CAO referred to at the very beginning of this budget meeting, is we've had the same model of staffing since 2000. We had one administrative person dealing with payroll, scheduling, and all of our documentations. At the March of last year or April of last year, we started bringing on a temp person to cover off and assist with our scheduling, our COVID-related calls. So that is a 5% budget increase, partially due to our additional costs, but that person was only brought on as a temporary measure right now through COVID, and that was one of our asks in our decision packages. I believe it's number 5 in our overall package. So we have currently right now one admin person to support our entire team until we brought on the temporary through COVID.
Okay, and that accounts for the 5% increase then, does it? Or the 5% overrun?
Through you, Mr. Chair, that's it's a combination of what Heather had explained to you and this additional temporary person as well. That temporary person is also shared between us and community paramedics and trying to utilize some of their budget dollars at the same time.
Michael?
Okay, yep, thank you. Thank you, Mr. Chair.
No worries. I think Michael has a little insight as well.
Sure, Mr. Chair, and we can dig further into this, but I think, as Russ said, we've got a bit of additional, we've got a bit of sick time happening in our admin group, so I think there's some overtime there that's probably pushing things up. As Russ mentioned, there's some admin support that we've had to bring on, again, dealing with some sick time and some capacity issues, but we can certainly dig into that a little further and articulate, express what that increase is on a line-by-line basis at the next meeting.
Thank you.
I have a little follow-up to that, and it's sort of spitballing, so, feel free to just take it as, a discussion about how some other community groups do their piece. But on the payroll side, and I don't know if this is a Heather question, a Russ question, or a Michael question, but I know when I was at the Grand River Community Health Center, the Brant Community Healthcare System actually ran the payroll, right? Is there any capacity within either the county or the city to take the payroll piece and do it out of office? So maybe that's a Heather question, I'm not sure, but, or Russ, or just something to think about, if there's any way we can offload some of that and absorb it either from the county or the city.
Through you, Mr. Chair, it's going back to the other part of the ask, right? Is our admin person is basically swamped with what they do day to day from our stat packages that they provide you and running the service and other documentation, purchasing, ordering. That person's an all-in-one person. Our actual payroll is actually done through our deputy chief every other Friday morning. That takes anywhere from 4 to 6 hours to balance it off with the current electronic schedule. Back 3 to 4 years ago, we did sign on to an electronic scheduling system, which has saved a lot of time for us rather than the old paper system. We just have not had the time nor the resources currently right now to basically build a API patch basically into our current payroll system to that one to take that extra 4 to 6 hours off of us.
Okay. Yeah, please, Mike.
Maybe just for clarification. So obviously at the department level and with paramedic services, they do scheduling. They've got some tools to help them. But then the payroll processing is handled by the county. It's handled through our finance group. So.
Okay. Councillor Sluss, I see your hand up and you still have time.
Yeah, sorry, I missed the second question. When we have folks, paramedics that are isolating, if they've tested positive and now they're off, or if they actually get COVID and they're off, how is that handled financially? Do insurance companies pick up that bill, or is that impacting our budget for payroll? How is that handled?
Heather's going to take this one.
Through the chair. We have been we track it separately because up to March, the province has paid full coverage for COVID-related costs. They haven't announced whether that coverage is going to continue or not, but we are still tracking it separately in the hopes that they will.
So does that mean it's coming then out of our pocket or an insurance pocket because of illness?
It would be municipally funded if it doesn't come out of the province. It's not covered by insurance.
So currently it's covered by the province.
Yeah, it's not covered today by the province. So if someone gets ill with COVID, the sick benefit portion of our compensation package does not kick in then. The city keeps paying that out of pocket, or not the city, but the service.
Correct.
Mike, did you want to speak?
Why is that not considered an illness and covered by a carrier?
Through you, Mr. Chair. So when I think it would be the same at the city when an employee gets sick on a short-term basis, they're just sick. They're still getting paid. They've got a sick time allotment. Every employee has a sick time allotment based on usually whatever your collective agreement says. So on a short-term basis, that cost falls to the municipality. It's just you're paying them regardless. Now it depends on the employee. So if I get sick, for example, I'm off for a week. Probably somebody's going to cover for me. I might be able to do a little bit of work at home, or my job just isn't going to get done. When we deal with more of a frontline service like a paramedic service or a police service or a fire service, I mean that you can't have that vacancy. So then we have to backfill that person, and that's where costs for these frontline services, and you would be the same with the city transit system. Again, we don't have a lot of options to not have those positions filled. So that's where the cost of the municipality falls on a short-term basis, and so COVID is still looked at as a short-term illness unless somebody gets really sick and then they drift into what we would call a short-term sick leave or a long-term sick leave. At that point, those longer-term leaves would be insurable. They would either have a workplace compensation claim or an insurance claim. But again, for the most part, COVID is, I think right now the quarantine period, isolation period is 8 days for a paramedic. It's 7 days for a paramedic. So yeah, we're on the hook for those costs. So as the treasurer said, for a good chunk of the pandemic, we were able to claim those costs back from the province. So that was a big help for us. That's why, because we did have, at various points, we had 10, 15% of the paramedics off with COVID, either, from exposure, so maybe not testing positive, but from exposure, or because of a positive test. And we were able to claim those costs from the province. Now, whether that's going to continue, I think that's one thing we will be looking for in this upcoming budget, because that's the whole healthcare system. I think we'll be looking for some coverage in the upcoming budget. Hopefully that clarifies things, Mr. Chair.
That's for me.
Just one thing on a definition then, Michael, what is short term? Is that 1 week, 2 weeks, 12 weeks?
17 weeks. So short term is 17 weeks.
17 weeks.
Yeah,
Okay. Okay. All right. Thank you.
Okay, thank you. Any other questions? So I believe Mayor Davis said he had a motion somewhat ready that he wanted to move, and we can have discussion after the motion is made as well.
Yeah, so my motion, Mr. Chair, is a motion that we defer our decision-making on the budget presented to us until our meeting in September, when hopefully we have a lot more knowns than the current amount of unknowns.
Okay, and just is there a seconder for that? Mayor Bailey, thank you. I want to get some clarity before we have our discussion. So one, Mayor Bailey and Mayor Davis, you're meeting with the ministry and you're going to discuss and very strongly advocate for innovation, funding fairness, and clarity about our budgeting and our processes for paramedics with the province. So that's one thing. I just don't want this to seem like, oh, it's a deferral with nothing happening in the in-between. There's a big push there from both our mayors. Also, we talked about to September. Now, if we don't get that clarity, Michael, there was still some confusion in my mind about when is the latest this can be moved to get that clarity. Like, is it January really? Is it December? We also have an election and new councils coming in, so I want to have it clear for them as well.
Sure. Through you, Mr. Chair. So I think, it's committees. I believe the Paramedic Services Agreement, I wrote most of it, so I'm pretty sure it's there, has some, there is some language to say that if Paramedic Services Committee wishes to defer the budget or to further delay it, that would need consensus of the two councils. But I would suspect that wouldn't be hard to get. So we've got options. When we get back in September, if things are still really unclear or more unclear, which they might be given the times we live in, then I think committee has the option to say, okay, well maybe we should defer consideration of this budget until the new year or until later in the year. These are all things, and then we'll just have to work. The two teams, the city and the county, would need to work to figure out how to slot that budget into the budget process. And our teams work very well together. We have great rapport. So I'm sure if that was committee's wish and supported by county council through resolution, then we could work that out. So I think there's a lot of options for committee and what to do with this budget during a fairly complex time.
The other addition to that, before you continue, with it being an election year, there won't be a committee for several, and this happened at the beginning. We had some discussions about the budget 4 years ago, but we didn't even have a committee to meet to be able to make a motion about certain aspects of it. So how does that timing work when it comes to the fact that, if we go past September, we go past October? I know we can technically meet until November, but what happens if it's really December or January and there isn't a Paramedic Services Committee struck?
Through Mr. So, the county would be doing its appointments process prior to the inaugural meeting, I believe, and I believe the city does the same thing. So, I think we would either or very shortly after I know the inaugural meeting is earlier than it used to be. So, but I believe we would have a Paramedic Services Committee appointed probably, by mid to late November. So that Paramedic Services Committee could, you know, start meeting again as early as December, I guess.
Heather?
Possibly with new members.
I see Heather with her finger on the mic trigger there. So Heather, do you have something?
No, yeah, because the term of council's moved up to start November 15th, so we have a little more room than other election years. So certainly by December, we should be able to come back.
Excellent. I just want all clarity on the table before we make any decisions. So Michael, do you have more you wanted to say?
Mr. Chair, one thing I just want, and I can certainly volunteer to do this without resolution, but I think there was some good discussion about some of those other things that the service could be doing. Now, again, we haven't spent a lot of time with committee on these other things because right now we just don't have what I would call a legislated or legal path to do these things. But I would think, you know, if committee wants to start, you know, becoming aware of some of these other things that are, you know, drifting around in the background of Russ's industry, we'd be happy to put more color to those things and present them to committee, just with the idea that, okay, there are some things moving through the system slowly that may help us mitigate this problem, because I think the other path is we just continue to you know, push resources into a system that seems to have some flaws in it. Not our system, but I think the broader healthcare system. So I'll talk to my team after this meeting, and we'll see if we can provide maybe a bit of an information report on some of these other areas, where they stand right now, what needs to change for these things to actually become reality, as opposed to just discussions. I'm happy to do that.
Being able to send people who are in crisis with mental health and addiction issues to St. Leonard's may be more effective and cheaper on the overall system. And it's, you know, well, one taxpayer's pocket, even if it's a little more expensive on the municipal side, it may be cheaper on the ambulance side, which helps as well. So yeah, things like that would be, I think, very welcome. Mayor Davis.
Yeah, thank you, Mr. Chair, and through you, in response to what Michael just said, and, you know, music to my ears, because in my opinion, is that this committee should grapple with these other issues that could make our paramedic service for our area one of the most innovative in Ontario, with the goal being to provide the level of service that our residents deserve and need, but at the same time managing it in a really innovative way to deal with the issues we've got, and not just simply kind of throw our hands up in the air and just do kind of with the only solution we seem to have, which is put more money into it. And that's important. We have to do that. But I, for one, just speaking for myself, and hopefully I'll still be here in December, would love to do that and encourage staff. My personal opinion would be to encourage staff to do that. And if it involves us spending money in kind of creative, innovative ways, certainly I'd have an appetite to see us do that, to change our service in the way that it seems like everybody knows we need to do it. We're having difficulty planning that path, how we get there. So thank you, Mr.
Well said, and I see a lot of nodding. Councillor Pierce.
Thanks, Mr. Chair. Yeah, I totally agree that we gotta, not saying that we haven't already, but we gotta continue to think out of the box on this for sure. But I think we also need to be very aware of, you know, if we're thinking out of the box, is it a pipe dream that the province is never going to go for, or is there actually some substance that some of these ideas that are being thrown around that the province is actually going to come on board? Because I would agree as well. If we have to spend some money to get a top 10 list, so to speak, then that's obviously what we want to do moving forward. But again, I don't want to waste money, and I'll leave that to to Michael and to Chief King and stuff like that, because they're, you know, closer to the discussions with the province. Are we going to hit a brick wall? Now, sure, we can do our damnedest to knock that brick wall over, but we also have to be realist in the same sense, in the fact of, you know, are these suggestions, these innovations, as we need, going to have any weight to them when it hits the province? So I'm absolutely all for thinking out of the box for sure, but I think we've got to narrow the scope to reality rather than pipe dreams at this point in time. Anyway, once we get them on board and they're willing to play nice, then maybe we expand to a potential pipe dream on that. But I think it's absolutely the direction to go. Thank you.
Thank you. Politics is the art of the possible, I heard. Also, I just want to mention that, so again, this is a deferral, but it's a deferral with a bunch of advocacy happening in the background and the foreground, and trying to get more clarity, because we just don't have the options we have options, but we don't have all the information. I want to say that in the context of the article that was recently in the paper about offload times, which we've spoken about here for a very long time. We're aware of it, and we are, funding ambulances ahead of schedule and trying to do what we can to support the morale of our workers, our paramedic workers, and hire more of them and the rest. But we want to do so in a system that makes the most sense for service and quality as well. So, a deferral makes sense, it seems, in this time, and I will call the vote if there are no other questions. Seeing no other questions, all those in favor of the motion? Councillor Sluss, are you in favor or against? Councillor Sluss?
Sorry? I was
we-
distracted. I had a call coming in that I was trying to monitor. Sorry.
That's okay. We called the vote. I'm just wondering if you're in favor of.
Yes.
Okay. It passes unanimously. Thank you. Okay, so with that said, thank you for the discussion, staff and committee. That was excellent. Let us move to 7.2 in our out of order agenda. Is that correct?
Yep.
Okay, 7.2. Russ, the paramedic services statistical package. Do you have anything to present, or is it just questions if required?
Through you, Mr. Chair, I'll answer questions at this time. We've had a lot of discussion about the increases.
Yep.
The only thing I'd like to add is on one of the statistical package that working with Adam and I is from 2014 to 2018, there has been almost a 61% increase in their calls. But for staffing, and we are working, and I appreciate everybody looking at it, we've only gone up about, so that would actually mean that as of today, we need 8.8 24-hour vehicles on the road just to maintain what we're at. And currently right now we're only at 7.5. So working through everybody here, understanding the extreme pressures that we're through, we as a service greatly appreciate the ongoing discussion.
Thank you. Mayor Davis, you're first in queue.
Thank you, Mr. Chair. And so we're at 7.2, the statistical package, right?
Yes.
Yep. And apologies, but Councillor Pierce may have asked these kinds of questions in previous meetings, and maybe I'm just catching up to them. But if I'm looking at the couple of data points here that raise some questions in my mind, Chief Kings. One is we'll call them the top 10 calls. I think you say these are the top 10 calls, and you've got them down by percentage, like weakness, dizziness, 11.25%. If I add up the percentages in that column, it comes out to about 47%. What's the other 53%?
Yes.
Through you, Mr. Chair, there's 209 different options for coding from our electronic ACRs. Those are our only top 10. Anything else below that is what the crews coded the person as directly. We're just giving you the top ones that, as you said, 47% of our calls relate to.
We can do a full summary, I'm told, though.
We can do a full summary all the way down to the very last call if we do so wish to do so.
Like for example, I would think, people think of ambulances as, someone's having a stroke or a heart attack, or they've been in a car accident or a serious injury. And I don't think I see in the top 10 or 11 like a serious a heart attack or stroke, or is that in one of these categories we're seeing?
Is it coded in a way that us lay people wouldn't understand?
It's through you, Mr. Chair. It is coded differently, not as clear cut as like a heart attack, not as clear cut, right? A VSA or cardiac arrest and stuff like this is coded differently, but that is not making a majority of our calls up right now. They are the far and few between. If you look at the stats right now, there's 65,000 cardiac arrests in Canada annually. Dividing it out to us, that we should see, I think in previous stats that I've looked at, in 2019, my last view, we only had 247 cardiac arrests in our community at that time. So you divide that out right now, that would not probably meet our top 10 list. Because your top one is weakness at 11%. 11% of 28,000 calls would be almost 3,000 calls regarding to weakness, dizziness, and unwell.
Okay, so the trauma injury category, 4.49%. Does that include like minor injuries and serious injuries, say coming out of a car accident, or like, so is that pretty comprehensive, including minor and major injuries?
Through you, Mr. Chair, trauma is a very broad discussion. When it gets broken down in our electronic ACRs, trauma is the master code, then it can go back to leg, chest, arm, or whatever the case is, right? It gets subsets built into it, but trauma could be you falling off a roof, trauma could be somebody skateboarding, or the trauma / injury at that point in time could be an MVC. These are just broad categories. If the committee does so choose, we can provide you a list of all the different options that the paramedics can pick at that point in time to break down those codes further.
Yeah, I guess I understand you're doing this based on, I guess, I assume Ministry of Health, very detailed, specific detailing, but you know, as a layperson, having none of that specialized knowledge, in my mind, I'm trying to sort out between what would be considered get these people to the hospital as soon as you possibly can, because it's very, very urgent.
You're looking more at acuity.
Yeah, and those other conditions where it's probably not as critical to get someone to the hospital in 5 minutes. And so it's hard for me, at least when I look at this data, to figure that out. Like what percentage fall into the category get them there quick, and what percentage fall into the category of get them there, but not as critically get them there in 5 minutes.
Through you, Mr. Chair, we have different CTASC levels, right? This is just what we find when we get to the patient's residence, or basically what we're done, sent out. But different levels are like a CTASC 1, 2, 3, 4, 5. I can break it down on how many CTASC 1s we get in a month down to all the way to CTASC 5 on return calls. The CTASC 1 is, to simplify it for, as you say, the layperson, a CTASC 1 is you need to see a doctor and or nurse immediately. A CTASC 2 is you need to see a doctor or nurse within 15 minutes. A CTASC 3 is approximately 30. A CTASC 4 and 5 could be anywhere from 60 to 90 to longer, depending on the minor injuries that the person has. But we can break that down. We're just giving you categories of injuries that we see, but we can also break down the amount of code 4, or basically CTASC 1, 2s, and 3s for overall urgency.
Okay. And if just one last question about Ms. Chair, it's the service response time standards. I think Chief Kane was just talking about it. We've got a spreadsheet showing CTAS 1 and going right through to 5. And when I look at this, I see that the CTAS 5, which is the least urgent of patients that we take to the hospital, we're meeting the response time of 15 minutes 95% of the time. I mean, that's great. But then I go to the top, and sudden cardiac arrest and being on the scene within 6 minutes, which we all know is absolutely critical in those scenarios, we're not, like, the benchmark is so much lower. Like, shouldn't that be the reverse? Make that 90% and allocate your resources accordingly. And CTAS 5, we can get that done 35, 40% of the time, then so be it. So I'm looking at this thinking everything seems reversed in terms of what we're achieving. And does this indicate a problem with the allocation of resources? And maybe it indicates a problem with dispatching. I don't know. So I look at this and I just wonder about meeting these benchmarks, and shouldn't we be striving for 90% on CTAS 1 and CTAS 5, 40%?
Through you, Mr. Chair, our Deputy Chief Kevin Robinson redid these stats. These benchmarks were the same benchmarks that were set when the province started reporting benchmarks back in 2013, 2014. We've kept them the same because, again, our resources were not required. A lot of communities dealing with sudden cardiac arrest have increased. Like, for the example, the city of Toronto has a cardiac safe community where they promote having more public awareness of public access AEDs. That 6 minutes includes you and I walking through the Gretzky Center, seeing somebody in cardiac arrest and putting the AED. That stops the clock. It includes the fire department coming on board and what the minutes that they did, right? This is basically, we are, as a community, that number should be a lot higher. It should be more like 60 to 70% for sudden cardiac arrest. But looking at our overall number, say we're only hitting 250 of those a day, we're only hitting one of those once every day and a half. So yes, those numbers should be a lot higher. Our CTAS 1s should be a lot higher, right? Those are the people that need our help the most. And they're the ones that are in more of a dire situation rather than, we'll say, the CTAS 4 or 5, that somebody's scraped their knee or whatever the lower acuity call is. But I am 100% in agreement with you. Those numbers should be changed. And we do have a draft that we did a couple years ago to address that issue at the same time.
Okay.
Thank you, Chief.
Okay, thank you. Also, when you're doing that CTAS 1, 2, and 3 breakdown, can we also have the 4 and 5s? Because I think that information would be good to have for looking at the different ways we want to defer, for lack of a better term, folks, or reroute people. The 4 and 5s, maybe, what percentage is it? Only 15%? Well, if it is, then there's only so much savings we can have. But if it's 40% and we're able to reroute those people to other centers for treatment than the hospital, that actually might be really impactful. So that'd be good as decision makers to know. Councillor Pierce, you are next in queue.
Thanks, Mr. Chair. Thanks, Mayor Davis. These stats have been something I've been kind of poking at for a while, and I agree, especially if we look at the CTAS 1, like we're the lowest percentage we've been in over 4 years. So again, I don't want to make ties where there's no ties, but is that due to 0 ambulances? And I'd be interested to understand, if we can, to let us know what factors are contributing to that, because it seems to be coming down as that percentage. And agree, if there's somebody that can wait for an ambulance, in my mind it's a CTAS 5. So I'm with you on that for sure. And you also alluded to the top 10 list. This is something as well, like you say, it's 47.15% of the calls. And then Russ, you stated that there's 209 different categories. I'm curious, I don't want to make ties where there's not, but is it possible that these 209 potential different categories are adding to the overall, I don't want to call it chaos, but I mean, it's got to be, if you're on the phone with somebody and they're trying to get an ambulance, I'm assuming that it's quite difficult within a couple of minutes to potentially understand. And I know your folks are professional, Russ, so don't get me wrong here, but with 209 possible categories to choose from, I think that's a heck of a task to try and break that down into the appropriate one. And that may assist us as well as, obviously, of those 209, it'd be interesting to get that full list of how many of those would necessitate anything above, CTAS 4 or something like that. I'd be interested to understand how they fit into that level of response time as well. Again, I think having the whole picture on all the categories and how they work out would definitely, it would help me as well. And the fact of getting the information in digestible format for us, us laymen here that don't really know the system as well as you guys. So if that can be done, and from what I'm hearing it can, I think that would be fantastic. And if we're in the midst of potentially revisiting those numbers, again, I don't want to go pipe dream here. I don't want to give us a number that we're not going to be able to attain. But I'd be curious to understand if this, in fact, is I think you said 2013 or 2016 when these percentages were given. I'd be interested to understand other municipalities if they're hitting that, what their percentage is for the CTAS 1 and CTAS 2, because to me, those are the if we want to call critical of the list, those are absolutely the ones that we want to pay more attention to. So no response required on that. I just wanted to state that I agree that having that information is going to be beneficial to everybody, and we'll see where that goes from there. So thank you.
Okay, wonderful. Sure. Oh, please, if you would like to.
Through you, Mr. Chair, just to clarify in the categories, when somebody does call 911, they say have a fractured leg, they have a fractured arm, right? My mom and dad is not breathing, right? They just dispatch the calls directly on the information provided, right? When we start getting down to the categories of mental health, behavioral, psych, unconscious, diabetic related, and all that, right? Those are the assessments that the paramedics do to basically fulfill our charting requirements to the province, so we can extract the data to see where we may in future focus in on resources or different ideas. But the dispatch center is basically more black and white. They give you they've got, I believe, 60 to 90 seconds to take the information and dispatch the call out, and it's just generic. My mother's not breathing, my mother fell down the stairs, right? They don't classify it as, they can tell you the history, but they're not the ones that are basically adding to our database on the trauma, behavioral, and everything else.
Okay, thank you. Okay, any other questions on this one? Okay, can I get a motion to receive as information? Moved by Councillor Pierce, seconded by Councillor Sless. All those in favor? And that is approved. Now we're moving to 7.3. Russ, this is your Chiefs update.
Through you, Mr. Chair, I'm just going to basically not follow my exact script. I appreciate everybody looking at the situation and the crisis that we're going through. We've had a lot of great conversation. We've asked for a lot of great clarification. As Mayor Davis has said, the call volume going up with 2% in aging population and 2% in overall population growth between the county and the city, and the other situations, lack of urgent care and stuff. That 4% basically on 150,000 people is about 6,000 if everybody picked up the phone and called an ambulance. The more that COVID, and we're still in COVID right now, the more that COVID basically releases the restrictions on us and the urgent cares and the doctors' areas are open to see patients, I can see our call volume going down a bit. But like at the Brantford General Hospital, they're just starting to look at construction now that will last 3 to 5 years, right? So these constraints that we are going to have on us, I believe will last 3 to 5 years. There's great discussion from the province. There's great discussion from our OAPC to try to think outside the box. Our service has been great getting funding for community paramedic, and our last funding letter was dealing with referral of mental health to St. Leonard's to help us out at the same time. I do understand it's a tough budget year. It's been tough on our medics for the year. We've all worked together in COVID. We didn't know what post-COVID life would be like at the end of this, and we're still in the middle of it. And I believe we're all experiencing right now. We're all going to have to make some tough decisions. I've just presented with the help of the CAO and our team here at the county on what we need to basically maintain our heads above water to serve the community to the best of our ability. Thank you.
I think it's very fair. Any questions? I have one question and one comment, Russ. My question is, in communities, and just to bring back the context of the health crisis, in communities when the ER is shut down, what happens to the paramedic services? If let's say next week the Brantford General Hospital shut down their ER for the weekend, what does that actually look like for our paramedics? So they can't say we're not taking calls. So what happens? Where do they go?
Through you, Mr. Chair, I'll go on experiences and discussions I've had through other services. A hospital did tell one of them paramedic service that they are closing the doors and they wanted to have an ambulance parked outside the emergency department to divert people. That problem or that solution was not the right solution, because if I showed up at that hospital with chest pain, that crew, according to the ministry legislation, would have to transport me to the closest hospital. I'm having 10 out of 10 chest pain and I could have a travel time of 45 to 60 minutes. Other ideas was to staff part of the emergency departments with paramedics at other services, again, limiting their scope of practice. As Michael referred to throughout our conversation here, we need to push the province, for additional funding and the ability to do more of a treat and release, that I show up at somebody's house and I can release you there rather than every patient having to be taken to the hospital. We did have another conversation with another hospital, and they first proceeded to tell the group that they were closing to all ambulances, which is against provincial regulation. But if we have to transport people out, say it happened in Brantford tomorrow, we'd have the patient in Brantford and we go in Hamilton and wait in their offload system, right? And let alone the 45-minute transport time in there, depending on what hospital you went, traffic and stuff, we're adding an additional hour and a half, basically both ways, no matter where we go. We currently have a diversion process in place, and it doesn't always work. I'd say it works about 10% of the time, in a relationship with Norfolk General Hospital that we call them, can we bring our lower acuity calls? If they are staffed appropriately, they'll take us. We'll go there, drop them off, and come back. rather than our crews waiting anywhere from 1 hour to 12 hours at any given time. We've had these conversations with the BGH on contingency plans, and we'll continue to work with them and provide as many resources as possible. But it seems, in my opinion, it seems like the norm that we're closing tomorrow, we're closing the next day and stuff, and they're basically looking at our paramedics as a safety net. Not on all the cases, but just that extra additional resources that is there for them. And again, we're strapped as far as possible. As we've said in our reports, if one of those hurricanes, or I mean not hurricanes, tornadoes or windstorms or ever came out right, or a large capacity, we don't have the capacity currently by the BGH and our staff to meet those needs.
Thank you. That's what I wanted to know. Councillor Pierce.
Sorry, Mr. Chair. Unfortunately, I have a hard stop that I need to drop, but I just want to say thank you to Russ and his team. I know it's challenging times, and I appreciate what you do every day, and I just want to thank you guys for that. And I appreciate everybody's discussions today. It has been great discussions, and I think we all understand that we've got a tough road ahead of us. But I think with the mindsets we have here, we will absolutely get to where we need to be. So my apologies again, Mr. Chair. I need to drop. I wish everybody a great day.
That's okay. Thank you, Councillor Pierce. We still have quorum. So the only other thing I wanted to say, and say as chair, I've been chair here for 4 years, and again, we don't get, at least in the county, we don't get people calling us, yelling at us about the tax rate, really. We get people who do call us and yell that they didn't get an ambulance at the time they needed. And I do think that when it comes to water and healthcare, those are things you can go directly to the public and say, look, we have to raise your taxes, sorry. But these are really important items, and when you're looking at the 3 to 5 year continual piece with the hospital, that part I think people understand is not going to solve itself overnight, no matter how much innovation we get, no matter if the province said, you know, we're going to loosen up the leash on all the different things. So often in the last 4 years, what if we did this? Well, we can't because of the province. What if we did this? Well, we can't. And that's not any one provincial government. That's how it's been for time immemorial when it comes to the relationship with municipalities and the province. So I would just say if this does get deferred, and if it does get deferred past my time here on council and committee, that I think, again, these are one of those, in the context of the crisis, in the context of being one of the leanest systems in Ontario already, I think it's something you can make the case. And the public's making the case. Like my Facebook timeline is full of pictures of, and it's stuff we're aware of. We've seen it. We've all driven by the hospital and said, wow, that's a lot of our ambulances out there. Now the public is taking photos, some of them from inside the hospital and some from outside the hospital. We talked just last meeting about how I had the opportunity to talk to a service in both sides, one in that way, one that way, and they both say in Brantford the offload is particularly bad, and we've brought it up to the hospital at council meetings. So again, just a little piece of commentary that I think when it comes to healthcare, this is something we directly fund in terms of healthcare, and I think we can make the case, and I think the community will be with us to make the case to do so. That doesn't mean spend frivolously and just throw more money at it, but it does mean that with hard choices, I think we can make the case quite eloquently about healthcare and water, and those are things that we're very responsible for. In municipally, it's with this paramedic services. So with that said, unless there's any other questions, I ask for a motion to accept the chief's report as information. Moved by Mayor Bailey, seconded by Mayor Davis. Is there any discussion on that? All those in favor? Okay. So really appreciate everybody's flexibility today. We have no communications or other business. Our next meeting is September 6th, not the 5th because of Labor Day. September 6th at 9:30. It will be hybrid as well. And hopefully we'll have lots to clarify so that we can make some good decisions. And if not, we have other plans in place to be able to defer if we need to until we get that information. Thanks again, everybody. And thank you, staff. Thank you, paramedics, and have a great day.